Good evening, all of you, to the 111th session of the weekly huddle. I'm your host, Anoop Agrawal, and joining me today is my colleague and co-host, Praneeth. We both are cardiologists working at KIMS Hospital, Secunderabad. You all know the format of the weekly huddle, where we basically take a regular clinical case scenario and then we engage in a very pragmatic discussion in terms of how we would address the particular scenario in our clinical practice. While we do want to talk about science, but the idea in the weekly huddle discussion is to help a physician translate what is established science into clinical practice. So we'll start with the case today, and this is related to a recently identified entity. I'm pretty sure it was there before as well, it's just that it didn't have a label. The entity called heart failure with recovered ejection fraction. And the clinical case goes something like this. It's a 46-year-old female. She came to our OPD for the first time. And she basically was seeing one of her cardiologists. And now her cardiologist moved out of station. So that is how she had to find a new cardiologist. And that's how she came to me. She has history of hypertension and hypothyroidism, for which she is on therapy, and they seem to be reasonably controlled. She was diagnosed as non-ischemic cardiomyopathy around 14 years back, and at that time she was about 32 years of age. I could not get a sense of whether this was related to peripartum, whether this was related to childbirth. She did say that the heart failure was diagnosed when her kid was pretty young, but she could not recollect exactly the chronology of how it happened. She does recollect that her ejection fraction was very low, and she was admitted for heart failure therapy at that time. She did undergo coronary angiography, which was reported to be normal. After a few months of therapy, she was offered an ICD for primary prevention, which she got it done at that time as well. Since then, she had been in regular follow-up with her cardiology. When she came to me, she could not bring all of her old medical records. It's been quite some time, and I could not trace all of that back. But she had the most recent follow-up note, which was more than 2 years ago. That is the last time when she visited her cardiologist, and since COVID started, she literally has not sought any cardiology opinion, partly also because she was feeling fine. So in the clinic, she does not report any cardiac symptoms. She says, I'm absolutely fine. I came here just for a routine checkup because it's been some time that I've seen a cardiologist. Her physical exam is pretty unremarkable. Routine labs are checked. They are also quite unremarkable. Her ECG shows normal sinus rhythm with non-specific STT wave changes. She did get an echocardiogram done with my request, and that echocardiogram showed near normal LV ejection fraction. She was her EF was noted to be around 35% with normal LV cavity dimensions, and this is something which I verified myself after looking at the echocardiogram. Her valves were okay, and there was no any other significant pathology on the echo. Her ICD was also interrogated, which showed normal parameters. She was pacing well less than 1%. There were no any VT events. There was no any therapy that was delivered. But the device was noted to be at ERI, which is elective replacement indicator. That means that you have about a year or so for the battery to be replaced. In this case, the ICD generator that could be replaced. She's on usual cardiac medications, which include metoprolol 100 milligrams, sacubitril valsartan as Vimada, which she takes 100 milligrams twice daily. And then she's on standard dose of spironolactone. She takes a little bit of torsemide along with isolazine, thyroxine, and other lifestyle medications, namely pantoprazole. And she takes what do you call multivitamin. That's pretty much about it. So with this particular case, I want to discuss on certain things. That is, first, number one, can her goal-directed medical therapy, GDMT, be down-titrated? Now, this is a patient who was diagnosed with non-ischemic cardiomyopathy more than a decade ago. Whether that was postpartum or not, it's difficult for me to trace that data. But her most recent echo shows that her LV is normal, and symptomatically she feels okay. So the question here will be, can we reduce her goal-directed medical therapy, or we need to continue the existing medications? I didn't mention her vitals. Her vitals in the OPD were, blood pressure was around 110, 112. Diastolic was 78, 80 or so. And her heart rate was around 80, 82, something like that. So her vitals were quite reasonable. So that was the first question, whether her goal-directed medical therapy needs to be down titrated. I have given you guys the medical therapy that she's on. Then the question is, any need for advanced imaging for decision-making, particularly cardiac MRI or any other advanced imaging? So far, I can see in her chart, she did not undergo any MRI or PET scan before for her etiological evaluation. Then should her ICD generator be replaced? Now, usually when we put ICDs for primary prevention, when the batteries go at ERI, we do want to replace it because most of the time the LV doesn't recover. And if the LV ejection fraction remains 35% or below, they're at high risk of VT, and it's a no-brainer that the generator needs to be replaced. But now, since our LV has recovered, should the ICD be, should the generator be replaced? Because with a recovered LV, whether she still is at the same risk of VT as what she was when her ejection fraction was 30%, that also is a question which is unanswered. And then with all these questions, should we manage the different subset of recovered EF differently? What if this patient had ischemia before? What if this patient had an inflammatory reaction like autoimmune disease or a viral myocarditis before, which has recovered now? Or patients which we get once a while with alcoholic cardiomyopathy and all those things, once they recover. Should all those patients subset be treated in a similar fashion once their LV recovers, or should we be making any differentiation in those? So these are some of the topics where I want the discussion to be. I want to emphasize that the scientific data is not very clear in terms of providing us guidelines on where to go about it. So we'll see what our cardiology colleagues in today's discussion, they add to it. So I'll start with Praneeth, and then I will move on with the rest of my attendees. So Praneeth, you got the questions. Tell me your impression about what is going on here, and how would you handle this case?
Yeah, good evening, everyone. Firstly, the terminology of heart failure is a bit getting complicated or overwhelmed day by day. Kind of, for the sake of audience, I'll kind of say about the heart failure thing. Now, we have heart failure definition based on ejection fraction. Anything less than 40%, we call it as a reduced ejection fraction, heart failure with reduced ejection fraction. Anything more than 50% is heart failure with preserved ejection fraction. And 40 to 50 is something which is heart failure with mildly reduced ejection fraction. Now, as a definition of heart failure with recovered ejection fraction, there should be a patient who has an EF less than 40%, and after treatment or after a course of time, the ejection fraction is improved more than 40%. When the EF has improved more than 40%, we call it as a recovered ejection fraction. And these are the recovery of the ejection fraction is possible in certain subset of patients. Yeah. So it is noticed in certain subset of patients, and managing them is the point of discussion today. So this patient who has recovered and who is clinically stable, question of whether we reduce the so-called guideline-directed medical therapy. You mentioned about so many drugs, out of which so far what we understand in today's knowledge is the 4 group of drugs which have been shown to be reducing mortality. RAS blockade, ACE-ARB ARNI, which patient is receiving, mineralocorticoid receptor antagonist, which probably patient is taking, SGLT2 inhibitors, which patient is not taking, and the beta blocker, which I believe patient is taking. Other drugs like isolazine, diuretics have been said to be reducing the symptoms, but they haven't been shown to be improving the mortality. Class 2 indication is ICD for primary prevention of sudden cardiac death. Now, for this patient, because she is asymptomatic and she's um, literally in functional class 1 or 2, I do not I do not think that she is requiring any of these other drugs like diuretics. We can stop, isolazine we can stop, and she is receiving some MRA and ARNI. ARNI, I believe, should be continued in this patient because probably ARNI has been shown to improve her ejection fraction. So if this kind of made her recover from the LV dysfunction, I believe it should be continued. MRA, and she is not on MRA and she is not on SGLT2 inhibitor. Regarding beta blocker, again, unless we have any strict contraindications, because this patient is a relatively young female and her hypertension is when controlled, we believe that Indian hypertensives, beta blockers are preferable antihypertensives, though is not in guidelines. So I would also advise her to continue beta blockers. Regarding ICD, in the last few years, which she had ICD because there is no documented arrhythmia and EF has recovered. There is no documented arrhythmia. I don't think there is any indication to replace the battery. So I would say leave that device then and there. Can we remove it? Pulling out an ICD device is a challenge in itself. Lead extraction is a big deal. Can you only remove pulse generator? Probably yes, but what is the worth of removing it? We are only adding a procedure with probably zero value of it. So I would say that your battery is going to go dead in some time and you may not need anything, and that is going to stay in the body and we kind of forget it. Reassure the patient that her ejection fraction is improved and she could kind of lead a reasonable normal life. Do we need to do any investigations like cardiac MRI or PET? Again, any investigation that we need to do should add value in terms of changing the line of management or making a diagnosis. In her case, both the questions are not answered. So doing any more investigations, I don't see any value in doing an MRI, PET, or etc. So I would reassure the patient. Probably stop the other drugs, continue ARNI and beta blocker that she's continuing, and forget about ICD, and ask her to keep in follow up once in 6 months to 1 year to make sure that her ejection fraction continues to stay the same. So rather than ordering MRI, probably I would do frequent echocardiograms, maybe annual echocardiograms, just to make sure that her EF is remaining the same or is there any other drop. This is the my take on this patient, Anoop. Any questions that I missed, I will be happy to answer.
So Praneeth, I'm going to be devil's advocate here. This patient who is feeling okay, whose LV has normalized, why does she need to be on drugs like Vimeda or spironolactone? Why does she need to be on all that, or all of that?
No, for this patient, we don't know what was the earlier etiology for her LV dysfunction. If there was something like a reversible cause, something like patient was having an ischemic heart disease, patient underwent a revascularization, or patient had any other uh, reason that we know for sure. Maybe a patient had a arrhythmia, bradyarrhythmia, or a tachyarrhythmia, which was corrected. Or if there is any known cause which we have corrected where you are sure that the reason has been rectified and that led to her recovery of ejection fraction, then I would be a bit more confident in stopping these drugs. Now, how much did the drugs contributed for her recovery, or that was an incidental event which has happened? I'm not sure. And because these drugs have been said to be improving ejection fraction to a certain extent, I would still be considering giving them drugs, because if these drugs were the cause for her improvement, then it would be the same. It is, I would try to use the analogy of hypertension that we use for these patients. Like, patients take medicines for hypertension, they say that my blood pressure is under control, I would like to stop. Because you are taking the drugs, your hypertension is controlled. If you stop them, your hypertension is again going out of control. So I would try to use this analogy. So if these so-called guideline-rated medical therapies have improved your function status and ejection fraction, it is probably worth taking them rather than stopping them. And that is my point of view. Anoop.
So few things, Praneeth, I'll just highlight what you said, and then I will go to Dr. Vijay Reddy sir, who can give his input on this. So you mentioned that if there was an obvious reversible cause like an ischemia, then in a recovered LV, you will be far more likely to take some of these medications off once the LV recovers. So that in part answers to my question number 4, which is, do we deal with different subsets differently? And that is again a point worth discussing, that let's say if this patient had a postpartum cardiomyopathy, let's say, or if this patient had ischemic cardiomyopathy, let's say, which has recovered now she's not getting any more pregnant. And hopefully now she's not getting any more MI, provided we correct all of these things. So is stopping heart failure medication a reasonable thing at this time? That is one that you mentioned. The second thing that you mentioned is the hypertension analogy. Now, we all know that if a patient whose blood pressure is controlled with antihypertensive drug, when they stop those drugs, blood pressure is going to come back up. There is no doubts about it. But do we know the same thing for heart failure also, that these patients who have got a recovered LV, once you down titrate their heart failure medication, do the heart failure actually come back? And if it does come back, then it is worth continuing. But if it comes back only in a minority of the population, then why are we subjecting so many patients to this therapy? And one thing I will just add, when you were mentioning about the definition of heart failure with recovered ejection fraction, so the baseline EF needs to be less than 40. The recovery needs to be more than 40%, but an absolute increase, there is a number for absolute increase also, and that absolute increase should be more than 10%. So if somebody starts with 35, then they need to have a EF of more than 45 to be called as a recovered EF. These numbers are arbitrary. They have been pretty much put in a recent expert panel. Whether it has got any relevance or not, I don't know, but at least that is the definition that you need to remember. So, Vijay Reddy sir, I'm going to ask you this question again. This patient comes to you, LV is recovered. The question here is whether we should continue these medicines, whether we should do any investigation, whether ICD generator should be replaced. How do you address these kind of recovered LV cases?
Good evening, everybody. My take, this is 40-year-old female who has got the dilated cardiomyopathy with severe LV dysfunction on 4 pillars of heart failure, GDMT. So, beta blocker, she is taking optimal dose, ARNI, mineralocorticoids, and SGLT2 inhibitors. I don't know the ratio of isologen in this patient, so I will stop the isologen. The patient heart rate is 88 according to you. I will prefer rather ivabradine rather than isologen in this patient. Now, as the LV function improves, the dilemma whether to down titrate the quartet of GDMT or not. The data, my feeling is all GDMT drugs, which includes ARNI, MRA, SGLT2, and beta blocker, should be continued, because, as you said rightly, there will be down regulation of the, once again, patient will go in for the earlier status, the LV function will decline. So we have to continue the GDMT. Point number 2, ICD was put in this patient as a primary prevention, and there are no VT events. So I don't know whether the MRI was done at the time of primary prevention of ICD. So most probably the scar burden must be very less, because we don't see any VT events. So I don't replace the ICD. So that is the number 2. And third thing is, the concept of the now the mildly reduced is also changing. Now in future, we are going to have only two things, either reduced ejection fraction and preserved ejection fraction. So most of the drugs like MRA, SGLT2 inhibitors, they are also proved efficacious in preserved ejection fraction also. So my take on is I will continue GDMT, stop isologen, no ICD replacement. I will add ivabradine because the heart rate is 88. That is my take. Thank you.
Sir, I have some counter questions to what you said. Now this is the case that came to me, but I'm just giving you a hypothetical scenario. Let's say if this patient was proven postpartum cardiomyopathy with the same kind of history where this patient had postpartum cardiomyopathy, started on therapy, did not recover for 3-4 months, put an ICD, but over the time now her LV has recovered. In this scenario, would you still continue GDMT after 12 years or 14 years, or now would you be more willing to stop?
No, GDMT should be continued. Even in peripartum cardiomyopathy also, GDMT in a preserved ejection fraction, even the LV improve should be continued for the fear of declining of EF.
Second question, and I'm again just giving you a hypothetical scenario. Second question, let's say if we do MRI, cardiac MRI on this patient, assuming that the device is MRI compatible, if I document there is no scar on the LV myocardium, does that give any better reassurance that the LV will sustain even if we stop the drug, or you think that's a false information? That's a false security?
No, I'm thinking about, you are asking about ICD. ICD, because it is a primary prevention in this patient. Anyway, beta blocker is there, which can act as an antiarrhythmic drug. I don't consider of replacing the ICD.
And how about therapy? How about medical therapy? Because if, let's say, I do an MRI and there is no scar on this patient, will that give any more confidence that this patient LV will not drop if I stop goal-directed medical therapy? Or you don't think that
if the scar burden is very less, it is unlikely to progress.
Perfect. Thank you. Thank you so much, sir. I will continue my discussion. Haigrif, sir, I hope you heard the entire discussion. I want your opinion, but more particularly, I want you to address this ICD scenario. Primary prevention, 14 years, device has not fired. Everybody is of this opinion that you keep the device as it is. I don't know the implications of leaving a dead device in there. If you could just share your thoughts about the clinical case and then particularly about the device.
Thank you, Anoop. I'm actually very excited because you have chosen a very nice case, because this is a practically occurring day, and I must have seen so many like this in the last decade. Now, two questions before I must have missed, but I just want to clarify. One thing is, was the patient hypertensive?
The patient has a history of hypertension, yes.
Great. And second thing is, you said I was intently listening, but you didn't say that. 2 years back, you did not find any records, but you did find a record 2 years back. Now, yes. You didn't say anything about the record of 2 years. What was the echo 2 years back?
So 2 years back, there was just old medical history and the medication. So she had a prescription from her old doctor, which mentioned history of this, ejection fraction 30%, 2000 some last year at the time of diagnosis, and currently doing okay. These are the medications to take. I don't think at that time any investigation was done, and previous history was not written. The old echo was written as a past medical history, but the current information that was 2 years back, that was not written in that prescription that I got.
Oh, great. That means
so she could very well be having a normal EF 2 years back also. I just don't know that. I just don't know that.
Yeah, great. Now, there are so many issues, starting from the ICD implantation till the ICD now, and other questions that you posed. Now, the first thing I would like to address is this kind of primary prevention thing. See, the primary prevention itself, based on LV function, although it is practiced in the West because of the guidelines, there's a lot of, I should say, controversy. The LV ejection fraction alone doesn't represent so many things that we know of. So the first thing is, when because we don't have any records at all, so we should be free to discuss as if all scenarios. Now, the first thing is to we do not give enough time for the LV to recover before implanting the ICD. That is one important point. Is 3 months and 6 months. People, we should all realize that it is after the maximal doses or optimization of guideline directed therapy, which is definitely not many times done. And second thing is, there are as Pranith did mention in his summarizing the different kinds of heart failure, there are actually, most of the times, even in CRT, we see many people say, I put CRT and then, the patient became totally normal. A large number of, or at least I should not say large, a significant number of these patients actually are patients, not responders, but actually reversible heart failures. They are people who would reverse otherwise also in a period of time. So adequate time to be given for ICD is the first point I'd like to make. So we jump too early, then the patient recovers, then all these issues of whether should we have put or not comes. The second point is what kind. No, I did make a comment that LV ejection fraction is not all. There's so many issues about it. Then what else? Now, cardiac MRI at the time of implantation of ICD is a very good investigation. It delineates patients, especially after a Danish trial. Now, this is a non-ischemic cardiomyopathy. Now, we do know that non-ischemic cardiomyopathy primary prevention by ICDs has not shown to be efficacious, but that does not mean that it is useless. We need to further substratify. So, patients with non-ischemic cardiomyopathy, practically no scar, we have a very low threshold of, or let's say we have a very high threshold of implanting ICD in them. We go discuss with family, talk them out of it, and unless they're very particular, should not. So that answers your question about different substrates. And the third thing now is that, having said that, now we have to, when a patient comes for like this ICD, ERI, and comes to us for a device change or a PG change, we have to be in India. I mean, more than anywhere else, we have to be doubting Thomas. Like I have been a doubting Thomas, right from we don't have records, but we have to doubt every step of it because the patient is waiting for our decision what is to be done. So now the point is whether the patient had a heart failure within a few months or within a year completely recovered to normal LV function. Did that happen, or did it happen, as one of the speakers said, over a period of time the guideline directed medical therapy helped it to become? We have no idea. So we have to doubt both of them. It could be that or it could be this. So now the patient has a absolutely normal LV. There is, first of all, in a normal LV, there is no need to do MRI to stratify or anything. We never do an MRI at all. So there is no need to do an MRI, and the patient definitely is not a candidate for ICD by any standards now. Whether or not he received a shock also doesn't make a difference, because now the patient has a LV and is normal. The third thing is, it is very extremely unlikely, if you do an echo now, that what I would say is, if the LV has become normal, it is what is called as a remodeling and reverse remodeling. That is what has happened. It is extremely unlikely that there will not be any relics of this remodeling on echocardiogram by any parameters. LV end-diastolic diameter, GLS, there would be some relics. It's extremely unlikely it would be completely normalized to suspect a scar or something. So this is my take about ICD. ICD need not be removed, because as Pranith has rightly said, now to subject the patient to another procedure with all its attendant risks is unnecessary. An ICD which is there in the body, because this happens to children many times to us, because the surgeons implant intra-abdominal or intrathoracic pacemakers, they are dead, and then we put a pectoral fossa, we put another pacemaker and the child grows up. Those pacemakers are left in situ in the child in the intra-abdominal for a long time, throughout their life for decades. So I think reviewing an ICD, if it's not infected or any other reason, I think there's no problem. You don't even have to think about extraction, or don't even dream about it. I think ICD can be left alone. Now, last point about your drugs. Now, I think we are very fortunate. We made our discussion very easy because patient is a hypertensive. Otherwise, we would have had some problems. Now, because patient is hypertensive, she needs some drugs. So we take, in my opinion, I would take off drugs like sacubitril, valsartan, and SGLT2 inhibitors without any hesitation, because these are the add-on or their incremental benefit over the standard drugs. So there's not much big deal about it. I think they can be withdrawn. And because you're serially following up with echocardiogram, you always have a chance to reintroduce them if you need be. But because patient is hypertensive, you choose those drugs which are also guideline directed, but which help her hypertension. I think that's a fair enough way to go about this. Anoop, I think I have covered most of your questions.
Sir, you have definitely covered most of the questions. So if I hear you correctly, so there is a case to be made that the primary prevention ICD in this particular case was probably placed way too early in terms of either they waited long enough, but they did not give enough medical therapy, or they gave medical therapy, but did not wait long enough. Either way, the heart was not given its say before and primary prevention ICD was placed. So I think that's a very, very reasonable thing to assume at that time. We still don't know the original pathology. You mentioned about GLS, and this is what I wanted to bring to the discussion, because she already has a device. The disease is old, but there would be some remnant of previous disease. And even if LV measurements and ejection fraction comes normal, universally these patients have GLS abnormality. And in this particular patient, if she does not have any other concurrent cardiac pathology, and if strain imaging comes abnormal or grossly abnormal, then I know this patient is very high risk for decompensation, and I wouldn't touch the medical therapy at all, because I know that the cardiac kinetics are deranged, and it is only one spectrum of those kinetics, which is LV ejection fraction, that has recovered, but rest of it has not. And the moment I withdraw the drug, there is a very high risk of these patients going back into decompensation. The question that will come is, if I do get a strain imaging done, and if that also comes normal, which I haven't done yet, and there is a very good chance it will not come normal, it will show something. But if it does come normal, then do we have a case for backing off on the goal-directed medical therapy? That was part of the discussion. And of course, science doesn't provide a clear answer to that. What you did mention is backing off on ARNI, and that also to a certain degree can be understood. Going back from ARNI to something like ACE or ARB, targeting hypertension, but also kind of giving a substitute for heart failure, that also could be a very reasonable approach in this kind of patient subset who otherwise have relatively normal cardiac parameters. Role of biochemical analysis like NT-proBNP or whatnot, that also may be something we can discuss. Diuretic stopping and stopping isolazine, I think that is a universal answer that I got from each one of you. But how about this GLS business if it comes normal, and is there any role of BNP? I am again trying to stress, can we back off on these medicines, because we are subjecting her for a lifelong therapy. If it has proven benefit, then definitely we should continue, but just for the sake of it, should we subject these patients for a lifelong therapy? And that is why I'm trying to re-emphasize that can we safely downgrade some of this therapy. So any role of biomarkers like NT-proBNP, ST2, or some genetic analysis that can be done? GLS role, if it is normal, can we back off? Is there any other thought process? So the floor is open for discussion. If anybody has got any thought process, including my earlier speakers, please feel free to unmute yourself and share your thoughts. Pranit, what do you think? If I do a GLS on this patient and if GLS comes normal?
Firstly, the probability of getting GLS normal is less likely because, as been told by the previous speakers, we are looking at ejection fraction as one of the parameters of assessing LV function, and we know that it has its own fallacies. And as we are digging deeper into various modalities, be it MRI, GLS, CAR, strain imaging, etc., we know that we are knowing better about various functions of LV or various abnormalities. The probability of picking these abnormalities is increasing. Now, so if this patient has a GLS which is normal, which is highly unlikely because the scar is a scar. Whenever there is an LV dysfunction, there is an injury to the heart, and every injury will lead a scar. If a near normal, then probably we presume that the amount of injury was relatively small, and hence GLS was also becoming is showing within the normal range. If that is the case, then probably the reason for continuing this drugs, we have to really be very much thinking twice to continue them. In that case, I would be more tempted to stop these drugs, because now I cannot justify in any way where giving these drugs particularly for lifelong, because patient is relatively young, and looking at every aspect of it, the burden of taking the drugs, the effects and side effects, and the cost associated with taking these drugs. So first question I would try to look into is, why do I ask GLS? Does it alter my decision? And if I have to make a decision of stopping these drugs, then probably I would add. And if GLS, in my opinion, if it's normal, then I probably will be stopping all the other drugs other than giving her plain antihypertensives.
Okay, let me invite Shankar sir in the discussion. Shankar sir, from a physician viewpoint, I know we are talking a little bit cardiology heavy topic. I'm sure these patients, they come to you who are also seeing their cardiologist, but they are coming to you, they are asking for your opinion. Doc, my heart has recovered now. Why am I taking all these medications? Or they may not be asking you. You may be asking yourself that, should I continue all these medicines, or is there something that I can do to risk stratify further? Give us your impression of this kind of clinical subset. How do you approach? Shankar sir.
Good evening to all. This is really a cardiologist discussion. But before I discuss about the management of this case in our perspective, I would like to go through this JAC scientific panel discussion, panel recommendations. Say Journal of American College of Cardiology, the scientific expert panel, they have given some recommendations in the year 2020. So this is from the Journal of American College of Cardiology. The working definition of, as already everybody has alluded to, the working definition for the heart failure with the recovered ejection fraction, there should be documentation of LV ejection fraction less than 40% at baseline, combined with more than or equal to 10 points absolute improvement in a LV ejection fraction, and a second LVEF measurement more than 40%. This is the working definition of this heart failure with a recovered ejection fraction. The patients with heart failure with the recovered ejection fraction have a 50% decrease in heart failure hospitalization, and there is improvement in the survival compared to the HFRF, the FRF and the FF. The biology of heart failure with the recovered ejection fraction is heterogeneous and depends on the underlying injurious process such as ischemia, cardiotoxic chemotherapy, alcohol-induced cardiomyopathy, and myocarditis, beriberi, and etc. The certain positive predictors of left ventricular ejection fraction recovery in heart failure. See, these are the positive predictors where we can expect the recovery of heart failure. Young age, here the same case, 46 years old, female sex, and the short duration of heart failure, and non-ischemic etiology of heart failure, the very few comorbidities, and the NYHA functional class at the 1 or 2, absence of left bundle branch block, the echo findings, like echo findings or cardiac MRI before we start treatment, the greater LV diameter, absence of late gadolinium enhancement, LGE, higher strain on this speckle tracking echocardiography, and lower biomarkers at low levels, that is like troponin and NT-proBNP and others, galactin and all. The use of beta adrenergic blockers also, it is a positive predictor for the heart failure recovery. The absence of gene variations and all. See, the predictors which I have alluded to, if they are there, in this patient, she is of younger age, female sex, non-ischemic etiology, short duration of heart failure. That's why she recovered very fast. So discontinuation, suppose I don't discontinue here the guideline directed medical therapy, GDMT, because in my clinical practice, if the patient insists to reduce the number of drugs, or patient on herself, if she stops medication, within 6 months or 1 year, they come with the same symptoms, signs and symptoms of heart failure. So discontinuation of the medical therapy in heart failure with recovered ejection fraction is associated with high rates of heart failure recurrence, more than 30%. So the GDMT should not be stopped. The patients with the heart failure recovered ejection fraction should be followed every 6 months to 1 year. Every 6 months to 1 year, they should be followed with echocardiography, ECG, and imaging should be obtained every 3 to 5 years to monitor the LV function, either the cardiac MRI, especially, that is an essential one. Then whether regarding the ICD, what they have recommended is whether a subset of heart failure recovered ejection fraction continue to benefit from ICD is unclear. So the beneficial effects of ICD is unclear because here the patient does not meet the criteria for the ICD already recovered. The ejection fraction will be more than 40-45%. So in non-ischemic or ischemic post-myocardial infarction, more than 40 days. So if the LV ejection fraction is less than 35, to prevent the sudden cardiac death, the ICD is indicated. But here, patient has recovered with LV ejection fraction. So that's why the recommendations regarding ICD, they are not clear. But expert panel supports the ICD generator change for most patients with heart failure recovered ejection fraction, and also recommends the CRT, the cardiac resynchronization therapy, should be maintained. And the lowest mortality recorded with the heart failure recovery, heart failure recovered ejection fraction, the 5-year survival rates are to the extent of 80 to 90%. Whereas in heart failure with reduced ejection fraction, the 5-year survival rate will be less than 30%. So coming to the management of this case, even after normalization of the LV structure and the function, recurrent LV dysfunction is accompanied by recurrent cardiac events in some patients with even with a heart failure recovered ejection fraction. The cardiac events may be seen. So reverse LV remodeling in heart failure recovered ejection fraction needs to be treated as a myocardial remission rather than a cure for heart failure. So cure we expect in certain cardiac illnesses like Takotsubo cardiomyopathy, tachycardia-induced tachycardiomyopathy, hyperthyroidism. The improvement is to the extent high as 100%. We can say that there the heart failure is cured, but in this case of non-ischemic dilated cardiomyopathy, so we cannot say that it is a cure of heart failure, but it is only a temporary remission. But with the cardiac events, she may go into heart failure again. So here the beta blockers, the foundation treatment here, foundation therapy. The beta blockers are associated with the improved survival in HF recovered ejection fraction, and they should be continued. Suppose if the patient does not tolerate beta blockers, then we can reduce it, but beta blockers should be continued. Then regarding the RAS blockers, the ARNI, ACE or ARBs should be continued. The MRAs also should be continued. Unless potassium levels rise or if there is a hypotension, then we can reduce it, or we can diuretics if there are no congestive symptoms. In this case, then the diuretics can be stopped. Then regarding this ICD, what this panel recommends, the prophylactic placement of ICD has been recommended irrespective of ejection fraction values for specific mutations in genes. So that's why genetic study, endomyocardial biopsy, then the CMRI, cardiac MRI, these are all supposed to be done in all cases of dilated cardiomyopathy. So if the genetic studies show the specific mutations in the genes such as LMNA, SCN5A, and FLNC, which are associated with high risk of arrhythmias, that's why the prophylactic placement of an ICD has been recommended. And also, if there is a history of appropriate shocks or persistent abnormal ECGs are seen with the same patient, then ICD is definitely indicated to prevent the sudden cardiac death. So this is regarding. So I continue GDM. Here I stop isolazine and isolazine, that is hydrolazine and isosorbide dinitrate here. I stop diuretics, and if the patient is on a SGLT2 inhibitors, depending on the situation, temporarily they may be stopped, but otherwise they should be continued, or they can be reduced to 5 milligrams of DAPA or 10 milligrams of AMPA can be given associated with this line of treatment. But the GDMT has to be continued. Thank you, one and all.
Thank you so much, sir. If anyone has got any questions or comments about today's discussion or case, please feel free to unmute yourself, or you can raise your hand and I will let you discuss what you have in mind. Alternatively, you can also put it on the chat box. And while you gather your thought, I will ask a few questions to Haigreve sir, who is here with us. So, Haigreve sir, we are talking about this device, ICDs, and Shankar sir mentioned about CRT also, in terms of what to do as a second event. So I'm going to ask you one patient which is not related to this one, and to get your opinion. So this patient is a 52-year-old guy who was admitted about 2 years ago with extensive anterolateral MI, and one of his presentation was a VT storm. He had a very stormy course requiring multiple shocks up to day 9 of his primary angioplasty. He was discharged on ICD for obvious reasons. He had VT for 9 days. Anything more than 48 hours, we considered putting ICD for secondary prophylaxis. So this patient was appropriately was given ICD for secondary prophylaxis. Since then, he had been maintained on therapy for coronary artery disease as well as for heart failure and VT, which included antiarrhythmics. It's been 2.5 years now. He has been off all the antiarrhythmics. He's maintained on goal-directed medical therapy for heart failure and atherosclerotic coronary artery disease. His ejection fraction recovered to 60% within 3 months of his event. And since that time till now, he remains in class 1 heart failure symptoms with no recurrence of angina. Echo recurrently mentioning ejection fraction recovered to 60%. ICD interrogation, not a single time showed a single PVC, let alone any VT or any therapy administered. He's 2.5 years now. Assuming that he spends next 8-9 years without any event, his device will also require a replacement. So this will be the same case I will be discussing probably after 10 years. That a 52-year-old guy with acute MI where ICD was placed for a secondary prevention because of VT storm around the MI episode. But from that episode till next 10 years, not had a single VT or ventricular rhythm with a complete LV recovery. Would you replace the ICD generator or would you leave it at that? I hope I was able to get the clinical case correctly. If there is anything I missed out, please ask me.
No, very clear, and you don't make cases easy. That I have learned from experience. So, Anoop,
now the thing is, this is a great question you asked. Now let us, because I said, unlike you, being a completely an Indian practitioner, I'm a doubting Thomas to every extent. So there are two ways I would like to think this case. First thing is to think that a patient had an anterior lateral MI. Now I want to know the ECG. What does the ECG, where are the Q waves on the ECG?
Sir, this patient, I did the primary angioplasty. This patient had a ST elevation. I actually hit him within 2 hours of his symptoms. But his MI was quite extensive. He had a ST elevation going from V1 to V6, 1 AVL with reciprocal ST depression. He had an ostial LED occlusion, ejection fraction of close to 20-25% at the time when I did primary angioplasty. He required
Q waves now.
So he does not have any Q waves now.
Great.
His ECG 1 month post MI is completely normal.
great. This is a very, very good case actually. Now let me talk about these VT storms which occur in acute myocardial infarction. There are two types of VT storms which occur in acute myocardial infarction. One is what is called as because of the triggered activity. These are not re-entry arrhythmias; these are triggered activities. They occur typically after an angioplasty. Now they occur because a patient has a large area of ischemia, like what you have mentioned, and the moment you do a primary angioplasty or any angioplasty, an electroangioplasty or early angioplasty, now you reperfuse a large area of myocardium. So there is an electrical, these fascicles, especially these anterior and posterior fascicles, extremely oxygen sensitive elements in the heart. Now, when you reperfuse them, these are the ones which reperfuse fast when compared to others. So there is an electrical gradient, and these give rise to a lot of VTs and VT storms. Now, your patient got away without any ablation, but many times you need to ablate the fascicles and get out of this difficult situation. Now, why I'm mentioning all these things is because the mechanism here is totally different. These are the patients who are just like a primary VT in an acute MI, like a patient presents with a MI, VT or VF, and then you treat the patient and the patient is all right for the rest of his life. Rarely he gets a VT. So these are something like that. Now, putting an ICD was absolutely right thing to do because the patient recovered from VT storm. You didn't know what would be the situation. That at that point, absolutely right. Now, the second type of VT storms are the ones which have a scar and a re-entry scar. So these typically occur after a, not so early after a primary MI, they occur a little later. So their prognosis is totally different. So those are the ones which will have recurrent VTs and they require antiarrhythmics and all this. So this patient, most likely from the way you told, comes under the first category, where he had a triggered activity VT storm. So these patients actually, they do well. Once they either die in the very first few days, or they recover and do well. So again, the second category of this patient, he recovered and did well. So this patient, most likely, if you, because there are no QAs, even you don't need to MRI, there are no QAs on the ECG, which are indicator of scar. So it's unlikely he has a scar. For the sake of completion, you can do an MRI and a scar, but my 2 cents of bet is that the patient would not have any significant scar. So this patient would not, if he goes with this, the way you're saying on MRI also, we need to have more than one imaging. Echo alone will not be enough. 2 imaging techniques demonstrating normal ejection fraction, no scar. I think you'll be fairly okay if you don't replace his ICD.
Yeah, so that actually needed to come from somebody who deals with it on a routine basis, because for me to leave a person without ICD where the indication of ICD was so-called secondary prevention will be a very gutsy move. And like in the index case that we are discussing for today's huddle, that's a primary prevention ICD. And there I think the decision-making becomes a little more easier. But in the secondary prevention, and secondary, I'm just going by the textbook definition, which is more than 48 hours of MI. In these cases, it becomes very, very challenging for a non-EP guy like me to make a decision to leave the ICD dormant. Of course, that will happen in his life after 8-9 years. But at that time, the decision will need to be made. He's a young guy, and I'm sure he will outlive his ICD. So I think with your answer, if we do MRI at that time, understanding that MRI will have its limitation with the ICD sitting there, and echocardiogram, if it remains normal, then it is okay to leave the ICD as it is, which is a dormant ICD sitting in his chest.
Absolutely.
Okay, it is 8:03. Anybody has got any questions or comments? We can continue. I have so many questions for High sir, but I think we will have to cut short because of the time. If anybody has got any other questions or comments, they can ask. And in the meantime, I will ask Praneeth to give his closing comments about today's discussion.
Yeah, I think we had a good discussion on probably an undercover topic. As we are knowing, or the literature is growing in terms of heart failure, these new terminologies are coming up and new entities are coming up. And this heart failure with recovered ejection fraction also probably we will be seeing more in our prescriptions. I think the aggressiveness of guideline-directed medical therapy usage is also increasing. Thankfully, so more and more patients should achieve the recovery in ejection fraction. Understanding that ejection fraction alone may not be a true representation of the recovery of function of the heart or the structural function of the heart. There may be a residual a scar or evidence of a previous myocardial injury, which we may know when we do advanced imaging techniques like strain imaging or MRI, which may reveal the previous injury or may equally throw a light on the etiology of the previous insult. Having said that, guideline-directed medical therapy, unless there is an absolute contraindication, probably should be given to majority of the patient, and the decision to withdraw supports or withdraw these important drugs should be a calculated guess, individualized. Only once enough evidence has been gathered that the etiology has been completely taken care of, or the LV has completely recovered structurally, not just going away only based on ejection fraction. I think that decision should be individualized, and we should have a very high threshold to withdraw these guideline-directed medical therapies which have proven mortality reduction. And just because these patients have become normal, They should not be left alone. They should be kept under follow-up. Close monitoring is equally important, maybe 6 months or annually, just to make sure that their course is on the same line and they are not deviating other way around. I think a very valid topic that we brought up today, and I hope we'll be discussing similar things which will enhance our clinical practice. Anoop.
Thank you, Praneeth. Thank you, all of you, for attending today's session, for your precious time and valuable comments. Thank you, Haigreve sir, for
Thank you.
attending after such a long break.
Thank you. The topic was so magnetically attractive. I could not resist. Thank you.
Too tempting for you. Thank you, all of you. I hope I'll see you again next Wednesday. You all know the drill. It's the same link that you click next week also. We'll
Thank
see you again for 112th session. Good night. Good night, guys. Take care.